one of the great medical schools in the East, 50% of the students were not going into clinics. They were going to work for companies, because they wanted quality of life. They knew they were going to make a good living. They'll be in their 30s and they got out of their training, whatever it might be, and they're already frustrated with the system, with insurance, with billing, with staffing. So that piles up on them. Get help, find somebody who can help you. If it's a family member, you need to ask questions, and you need to go to bat for yourself. And if it's an external source like a patient advocate as you, then go for it. There's not always a right or wrong answer to every problem you might have. And there may be a solution that you don't see, or the doctor doesn't see, somebody else sees. So you have to be open-minded.
My name is Rachel Nash, and I am very excited to have Dr. Zollinger here with us again. One of my favorite guests to talk about the evolution of medicine and where we are now and what it looks like where we're headed. So Dr. Zollinger, if you could introduce yourself and just tell the audience a little bit about yourself.
Well, my name is Rick Zollinger. I grew up in Ohio. Traveled around a bit. I went to medical school in Chicago. Then I trained at Ohio State University in general surgery. And then I did cardiac surgery at a place called the Ochsner Clinic in New Orleans. And then I moved back to Charlotte. I was undergraduate in North Carolina. Surprisingly, I came from Ohio to go to North Carolina. But then I moved back to Charlotte and practiced cardiac surgery for 20 plus years. Then quit from that and moved on into wound care, which was developing, and taught that and did wound care locally in Charlotte for a decade, and then moved into what's called executive coaching for physicians. And I'm still tied into that sort of, and trying to do some writing.
So tell me why the transition to wound care. What's that about?
Well, the deal with that was I was probably the first example, like I said, of physician burnout before anybody talked about that. So I retired, but way too young from surgery. So one of the administrators who I had good rapport with calls me and says, you're too good a doctor to not practice. We're going to start this thing called wound care. Would you like to help us set up the first center in Charlotte? So I said, sure, why not? What do I got to do? So I helped set up the office, the empty shell of an office, and I had to go off and learn about. Went to Texas and took courses in hyperbaric medicine, which is oxygen to help heal wounds, and wound care. And then because of my background in vascular surgery, the man who did that said, would you come back and teach, because you know everything about the blood vessels already. And the people who did wound care are, what makes it fun is it's any kind of physician. So, you're so in your closet for your specialty, but wound care, any doctor can do it, an ER doctor, a surgeon, an orthopedic, a dermatologist. So it made it a lot of fun, because when you get together or at a meeting or anything, the backgrounds are so totally different, but the focus is all the same to heal a wound. So that was a lot of fun. So I did that, and then the companies got sold and resold, and so all the people I knew went away. So that's when I kind of left that.
You mentioned physician burnout. Can you explain that a little bit more?
Well, I think some of that was probably personality driven by me, my personality. But now when you hear about people, especially in specialties like mine, or neurosurgery or things like that, day in and day out, you do lose patients, you do have complications, and you do have families. And you hear now about everybody wanting to raise their family and, have personal time and this and that. Well, I tell people, my family lived very nicely, but I didn't see them till I was 50. So, and then I'd see my friends, go off for the weekend or do things like that, and go to the ball games that I couldn't get to. So that all piles up on you. My father was no longer living, or he would have just beat me over the head with a ball bat, and probably gotten me through it. But he wasn't. So, but life goes on. I mean, people in real jobs out in the community They don't go work for IBM for 30 years anymore. They
Right.
might have 4 or 5 jobs by the time they're 45. So I look back on it, and everything was a lesson, and there were positives to every step I took.
What about physician burnout today? What does that look like for our physicians?
Well, I think what sadly it looks like today, I guess maybe I've told you before, I read something, I don't know about the numbers exactly, but one of the great medical schools in the East, 50% of the students were not going into clinics. They were going to work for companies, and because they wanted quality of life. They knew they were going to make a good living. So they weren't going to clinical medicine. So think about taking 100 graduates and 50 of them don't become your doctor.
Right. That's
so
huge.
And then the ones that do are getting out, and they'll be in their 30s, and they got out of their training, whatever it might be, and they're already frustrated with the system, with insurance, with billing, with staffing. It's not the patients ever. That's the fun part. So that piles up on them, and they want family, and they want quality time and all that kind of thing. I can't say exactly what it's like in the hospitals anymore, because they went through a process in the last 20 years where the hospitals bought practices.
Okay.
So there are not as many independent where, you are your own entrepreneur or your own business. There are a few, and it cycles, but I think it's frustrating. Physicians were used to being their own boss. So then it was like herding cats with administrators taking over. And now, if you look back in the 90s at the number of hospital administrators, there might have been 100, and now there are 1,000 for the same processes. So physicians get frustrated with that. So that's part of it.
I don't think people on the other side they don't realize that. Sometimes I think people blame the doctors, and they're not able to see the hierarchy. Would you agree with that?
Yeah, I mean, there's the business hierarchy of medicine is less and less in the provider's hands. It's in whoever manages, be it insurance companies, be it the pharmacy middle management for your drugs, CVS, Walgreens, your hospital system. So it's for the average person. I mean, an example of that is I've had my own child, and it's taken me a year to understand Medicare, Medicaid, secondary insurances, and what they cover, what they don't cover. And then you hear now that they talk about cutting Medicaid and all that stuff. If I don't understand it, I don't know how my neighbor gets it.
Right.
I just don't.
It's very
complicated.
Very complicated.
Yeah. Very
complicated. What does the word advocacy mean to you, and how important is it today?
Well, I think it's very important. I mean, the premier advocate for any patient is family.
Yes.
So if you got it, and you can't be sheepish, there's no question that's too dumb. Okay. You just ask. And good staff, good nurses said, well, why are you doing that? Well, because we're going to, okay, thanks. That's the key, is communication, and the family has to be the proponent. And if they don't understand something, or they don't like something, and they got to talk to the nurse, the social worker, the doctor, then that's what they got to do. Now that's developing with folks like you who are understanding that the family who's trying to do that, like what I just went through, is banging their head on the wall, and they need somebody to help them bang their head with them.
Right, that's true.
So I think it's the development of something that's needed. I just do.
Are the systems? Do you think sometimes I think are the people within the systems just too busy to take the time to communicate? Is there enough time to communicate anymore?
No, I think the staff and the leadership in the hospital, I think they're good people, and there's communication there, but there is so many hoops to jump through, from whatever it is, from payment to quality to errors in judgment, errors in medicines. I mean, there's so many things to pass through that it's just very complicated.
In your experience, when advocacy is present, whether from a family member, a nurse, or an outside advocate, what difference does that make? What is the difference that makes?
Oh, I think it makes a huge difference because it helps with the outcomes, whatever that is. Getting home, getting to a facility for help, getting physical therapy at home, nursing at home. Can the family member handle the care? So everybody needs some advocate. The hardest one is somebody who doesn't have family.
Yeah.
Or somebody that way. But no, I think it's just something you have to have in our present day.
Of course.
And whoever it is, whether it's family, staff, nurse, whatever.
Yeah.
And the good ones, for example, in whatever you touch base in the hospital, the nurse, the LPN, whoever it is, the good ones have that in mind.
Right.
They're busy and they're getting hammered, but
they care.
They care.
They care.
Yeah, if you weren't empathetic and sympathetic, you wouldn't be in the job.
Okay.
Yeah. You might get frustrated, but you
care.
You care.
You go into nursing or you go into medicine because you care.
Yeah.
But there are probably barriers that get in your way sometimes where it creates frustration.
Yes.
Because of the way the system is
and
designed.
The system is always an evolution. I mean, if you go back over the course of any physician, nurse, and say, how has it changed over 30 years? I would say that the benefit of nursing, and I told you that's what was fun for me with wound care, the benefit of nursing is you become a nurse, either an LPN, RN, whatever, you've got a Medusa's head of job career paths. You can work in an office, you can work in the OR, you can work in the ER, you can work on the floor, you can work for home health. So nurses go through, and when they hit that wall of frustration, they can say, okay, I'm going to move over and work in the GI lab, outpatient Monday through Thursday, and maybe I got a little less pay, but I got better hours or whatever, probably not less pay. But that being said, they can deal with that and still be a breadwinner for the family, So I've always thought that was it's kind of like you're always going to need toilet paper and you're always going to need nurses.
Yeah. Is there high burnout with nurses, or do they just go into different directions, which is a little bit easier for nurses?
When I was there, and see, I've been away from the clinical part now 4 years or more. I think there was, and there still is, but they have the ability to transfer, like I said. For example, one of the things young nurses will do now is if they have no family, they can be itinerant. So, for example, Mayo Clinic had a process where you spend your summers at Mayo Clinic in Minnesota and your winters at Mayo Clinic in Florida. Wow. They had the best of both lives. Now, once they find a family member or whatever, then that ends. But they have lots of options.
So you were talking about the hospital system a little bit. Can you explain what a hospitalist is and a little bit about that title and when that came about?
Yeah, that hospitalist is a whole career that came about in the last 25 years. It didn't exist before the turn of the century. Okay, so because your internist and your family practitioner made rounds on their patients in the hospital, and they wrote the orders and they billed for their visit or whatever. So if Dr. Jones is your doctor and you were on the third floor after an appendectomy, he came in and took care of your diabetes and your lungs and whatever. So what happened was they started cutting back the payment systems and whatever, and started to make the internists and family practice and those folks see a higher volume of patients to make the same income or whatever. So the payments changed, whatever. So what they did is they said, okay, here's what we'll do. You don't have to take ER call anymore and come to the hospital. You can come to the hospital and see your patients, But you don't, you know how if you call the office and it says, if you're really sick, call 911 or go to the emergency room. In other words, just skip us. So when you went to the hospital, they developed a group of physicians who are physician extenders, only they're MDs. So I'm Dr. Jones. I send my patient to the hospital, and the hospitalist picks up the level of care, does the orders, follows me through to discharge, and they call in the different specialists you might need, infectious disease, physical therapy, general surgery, whatever, and they're kind of become the captain of the ship in the hospital. So that's a profession that didn't exist. The only part I find hard with that, which compared to when I was practicing, is there's no captain of the ship. And by that I mean, if you come in, the kidney doctor does the kidney, the infectious disease does the infectious disease, the general surgeon does the wound on your appendix. But when the family comes in, who do I talk to about, well, that's the kidney doctor's problem. Well, that's the, and so that falls to the hospitalist, but it's just different. It doesn't feel it feels a little bit cumbersome.
Could that be why, because this happens all the time, families aren't able to talk to the doctor because is it possible that's the reason?
Well, because
they can't get to the doctor.
Right.
Because maybe it's the other doctor or the kidney doctor.
Well, you actually have to almost schedule an appointment within the hospital to see that doctor, know when he makes rounds, or have the nurse call him. And, it might end up that you talk to him on a phone or something like that. Whereas in the old days, it would have been that I went by always in the morning and the afternoon, and somebody that worked for me would see the patients during the day and say, well, you need to go back again and check on so-and-so because the family wants to meet with you. And, okay, fine. And that's a little bit not as smooth, I think, anymore. At least that's my impression going in as a client versus being in the house working.
So was this set up for money? Is it to prioritize money over people versus, no?
Well, I don't know. I don't think it was set up to prioritize money. I think it was set up to try to help make it more efficient. It was trying to help the internist and the family doctor to see more patients in their office practice and kind of take something off their plate so that they wouldn't have to deal with it. Now, in the end, a lot of that was money driven, I'm sure. And then when you get into the hospitals and how that's managed, that's, how fast we get you out and, all those kind of things. That falls to the hospitalist to take care of that kind of thing.
Right. I notice I do follow some on social media. I follow other board certified patient advocates. And I sense sometimes there can be, or advocates or even patient advocates, just patient advocates in general, that, we sometimes think, oh, the system is so bad, which it is bad because we see that with our clients. But we also, for me, I want to establish a relationship with people within the system because, as you said, the nurses are good, the doctors are good, the people that went into these fields, they went into them because they care about people. So, but I think sometimes when people see advocates, maybe it's the word advocate.
And it's roadblocked.
Yeah, there is a roadblock. And, whether people are litigious in nature, some people, which scares people, but, we're not there to cause problems. We're there to help bridge whatever gaps.
To me, it would behoove the hospital systems to manage that process there, to have, for example, if you have somebody who speaks Spanish, you have a translator that comes in or that kind of thing. Well, same would behoove them to have advocacies that connect with people on the outside that do your job, and on the insides, and that you can form relations, because it's all about relationships.
Of course.
It's the old doorknob doctor that stands by the door. You always have to touch somebody, shake their hand, meet them, whatever. Well, So I think that's what has to happen. I think the hospitals, that, and therein comes a whole nother, because, I guess in the hospital, some of that falls to the medical social worker. But in a big system like we have in our town and many towns, they're overwhelmed. They're trying to work for 50 patients,
Mm-hmm.
or, get them placed, get them home, get them what they need. So, their plate is full and they've got tunnel vision. So it's hard to say, you almost have to have a thing where you had a floater.
Mm-hmm.
You had the floating in-house patient advocate, maybe.
Right. I think that's a great idea.
That could connect with the outpatient patient advocate to say, well, what does this family need? What are their frustrations? What are that? And that may be a good way to go.
Talk a little bit about, because I know you did on the last podcast, because I even think that, when you think about social workers or you think about case managers, the story about the doorknob doctor could be true with any profession, correct?
Correct.
In how we communicate and how we can come in and bond with our clients. Can you talk about the doorknob doctor? Because that's one of my favorite.
Well, I think that's true. Like you said, what in any business, banking, real estate, whatever, what it makes a great leader. It's not the one it's the one that comes in and says, what do you need? How can I make your job easier? How can I make our company more successful? Not the guy who comes in, turn that, do this.
Right.
So, I think that's where I just lost my train of thought there. I was looking.
The doorknob.
Oh, the doorknob doctor. Well, yeah. The bottom line there was what has come out of the last 5 years with the pandemic and Zoom is that everybody thinks, the younger generation especially, thinks that you can succeed or get ahead without ever forming those relationships where you have face-to-face contact. And what I say about the doorknob doctor, the explanation there was the physician who comes in and sits down and touches the patient, may be there a minute. The patient who stands, or the doctor who stands by the door and holds the thing, stands there 10 minutes. And the patient his impression is the guy that was there a minute and had hand-to-skin contact
Mm-hmm.
was more attentive than the person that stayed 10 minutes.
Yeah.
Oh, he was busy, he had to go. So I think that translates to anything you go. I think as we've come out of the pandemic and we work through Zoom, if you're in sales, for example, at one point I got to go meet you. I go, oh, Rachel, let's, we have a drink and we had dinner and what's your widget and stuff. And then you can call me from Afghanistan and say, can you order me? Oh, sure. I'll get you 1,000
Right.
widgets. And I don't have to see you face to face. I can Zoom call you, FaceTime you, whatever you want to do.
Right.
So yeah, I think personal contact has been lost, and I think it should come back into any occupation, not just medicine.
I wonder, I told you when I was little, I was seen at Hopkins, right? That for Graves' disease, which was very rare for a toddler.
Yeah.
And I wonder, I had such wonderful memories of my doctors. And to me, I thought I was there all day and they were paying attention to me. Maybe they were all doorknob doctors, perhaps, or some of them were, because they were so kind.
Well, you have to understand too, if you're in a facility of the caliber of Hopkins,
Okay.
or the Brigham at Harvard, or Ohio State University hospitals where I was, Duke University, whatever, you've got all the staff, all the students, all the young staff, young nurses, young doctors in training, out of training. So it's really a vibrant place to be. That's when I started out, I wanted to do kids because of that. If you go into a children's hospital, it can be scary and depressing, but at the same time, it's overwhelmingly exciting.
Okay.
Because the patients that you work with, the best way to put it is, if you take an 8-year-old kid who comes in with some problem, let's say a liver tumor, they haven't screwed up their body yet. They're still out running around. They're happy. They're doing. you'd be amazed at the procedures a young child can go through and come out in 48 hours and they want a Big Mac. You and I'd be 6 weeks before we could walk. So it was always fun to see that, and the people who work there are positive. The nurses in the intensive care units, and a lot of these hospitals have Wendy's and McDonald's and ice cream stands in the lobbies, and they make sure the kids get out in a wagon and see the air. So that would be my impression. I've always been impressed with children's hospitals, and we have some great ones in the country.
Now, when it comes to teaching hospitals, your Duke and your Hopkins, do children, first of all, do children have access? Adults don't always have access to teaching hospitals. It has to do with their insurance.
Right.
Is it different for children with access?
I don't know, but I think so, because you can't go to the community hospital with X as a child. They're going to have to transport you to a facility that does that. Now, the one that always shakes all of our leaves a little bit and gets us thinking is Danny Thomas and St. Jude, because people come there and nobody pays for anything. It's all covered. Now, they've over years and years have probably built up such a huge endowment that they can cover all the, and I don't know the finances of how it works, but it works. And so, yeah, I think in any big city, in this city, for example, now, the hospital systems keep developing the skills. They're not going to turn away a child. They're not going to turn away an adult, but they may, it's different. You're right. And I'm not sure why that is, except we all feel like a child shouldn't go without, and the 60-year-old's been alive for a while. I don't know.
Right. Because not everybody has the ability to go to Hopkins or Duke or the right insurance, and they have complex issues that would be better served in hospitals like those.
No, for sure. I mean, that, and to answer your question, that's the deal. You can have a very complex adult illness and with no insurance, and you may not have any opportunity to get really treated. And if you go in other parts of the world, Europe and places, they're not going to dialyze a 65-year-old patient. The United States will dialyze you if you're 88, and, kidney transplants, different things like that. So yeah, it's different.
So if you could write a letter to the healthcare system and change and revamp it and make it good for everyone based on what you've seen, what would you say?
That's a tough one, because I don't know that there's a one size fits all answer. Everybody talks about having universal health care.
What would that look like?
Well, I mean, the example of that, you get on the physicians and you talk about it, well, that would look like Great Britain or Canada. And you can be on the waiting list for a year to get your hernia done, whereas here, you're going to get it done. You go see the doctor and you'll get it done in maybe longer than it used to be. But I think access, I'm just not sure. Our system is so based on the monetary side of it. And there's so many middleman people in the process, from the pharmacy business with the drugs, from the administrators that run hospitals, for the reasons I said. It's like a bank. Every time a bank merges, everybody in middle management gets canned. They got about 100 executive VPs of what? And so the overtaking bank will eliminate a lot of those jobs. And eventually something like that's got to happen with the healthcare system, but that's on the business side. But to answer your question from a patient perspective, I don't know that I have the answer to that. I mean, I think everybody should have access for sure. And the way our system right now is, okay, fine, who pays for it? I mean, like, for example, the saddest part now is you'll see articles about how You go to the emergency room and the hallway has become a room. Well, that shouldn't be.
It is.
But it is.
It is.
Yeah.
More
and
people in the hallways than in the.
Well, part of that has to do with how the patient is labeled and payment. So if you stay in the hallway and you're labeled outpatient, as long as you're there, the remuneration is higher than it is if you're admitted as inpatient. I don't know all the specifics of that stuff, but it's, that complicates everything.
Yeah.
It has nothing to do with 15 years ago, I said to family and friends, if you had a problem, rather than, this is when this was all starting to develop with emergency rooms. And then what did they do to treat that? Well, we came up with urgent cares, everything to try to unclog the emergency rooms, right? And so I told people, well, the best thing you can do is have a neurosurgeon, orthopedic surgeon, heart surgeon, some surgeon, and you call him, and I'll get you direct admitted, and then I'll call the in fact, whatever kind of doctor you need, and say, okay, you take over care, but I just get you direct admitted and write the orders, and you didn't have to go through the ER.
Okay.
You can't do that anymore.
So perhaps with universal health care, it could take longer to see a doctor, but it's getting harder and harder to get in to see a specialist.
Right.
I think right now with psychiatry, to get a psychiatrist,
6 months probably.
It's around 11 to 12 months.
Yeah.
To get in to see a psychiatrist.
Well, because they're so few. And so it's kind of like any other business. It's driven by the market. Mm-hmm. One of the places I have seen in the last 10 years and it's now exploding, is that the need for adolescent and young folks, both psychology and psychiatry, mental illness. We've had this explosion of anxiety and depression, all this going into 16 to 25-year-olds. Why is that?
Why? What do you make of that?
Well, you can't blame it all on social media.
COVID?
No, I think this was pre-COVID.
Pre-COVID.
You were already seeing there was nowhere that kid could go. The school nurse, and then there weren't any adolescent psychiatrists. Now there are clinical psychologists, and I'm sure now that's changed. But I just meant that was, and then COVID made it worse.
Okay.
Kids weren't going to school. They were, and the kids, think about all the kids who were getting educated who didn't have access to the internet or computer. What were they going to do? Go to McDonald's?
Yeah. And
sit there and do their classes if they come from a lower income family? So they got lost.
Or the attention span.
Yeah, they got lost.
To sit there or not being distracted by all of the things around them.
Yeah. So that's all social stuff, which we're not going to cure today. But all those things relate. I think social media, I in fact find myself, just like with the elections and stuff, I stopped watching news.
Yeah.
I pulled away from a lot of stuff. I pulled off X, things that just, I don't need that.
Right.
It makes me sad.
Yeah, it does.
Well, I don't want to be sad. I'm old enough, to hell with that.
And we're polarized too. We're one or the other. There's no middle ground anymore. It seems that way to me.
I think the last time we were not a polarized American society was 25 years ago.
Wow.
I think the last time you ever saw the government function that way was with Clinton.
Yeah.
Where okay, what do you need? What do I want? And the government functioned like that. Now it's just this or this.
But when we see our leaders and our politicians being so angry and they're the leaders, so they set the precedents, right? And,
right.
We're one or the other, and and I believe there's happiness in the middle.
I think when you talk about universal health care, getting back to the healthcare part of it. Getting back to the healthcare part of it, it still all comes down to the almighty dollar. How are we going to pay for this? Or we need to cut Medicaid, or we need to cut Medicare and Social Security and those kind of things. But how do you pay for it? You know, and that's what you always hear if you listen to television. How are we going to pay for this?
To understand universal health care, is it because they have higher taxes? And that's how they're, I mean, how are they paying
That
for
I
it?
don't know.
Okay, I was just
mean,
wondering how that's.
You know, I mean, you'd have to ask somebody from Sweden that has, you know, in those places. But now that's the other side of it. That there are countries like that that have excellent health care and excellent outcomes. And for example, for all our money, when you talk about perinatal care and stuff, our results over a lot of developed countries are much lower. So why is that? You know, so
Right.
So there's something to that.
Right.
The efficiencies of how their systems run. There are inefficiencies, but there are also efficiencies.
Right.
I mean, an example of that is the buddy I trained with, who's the head of all surgery in Czechoslovakia, cardiac surgery. But that was the deal. Their hospital in Prague was the center, and that's all they did. And they got people from Bulgaria, Romania, whatever. They would come to Prague,
Mm-hmm.
and these guys just had great care. And we have that at places like Cleveland Clinic or Texas Heart, which are like that, but we don't have one. I think with certain things, that's probably how a lot of this will develop. We'll get centers of excellence. And so you need certain thing done, you'll go to that place.
So, what gives you hope today about medicine? What are you hopeful about? What's really positive out there?
I want to be Michael J. Fox and go back to the future, and then I want to come back because I don't want to know about, you know, wars and stuff like that. But the medical advances are, you know, how we are all talking about AI and how everything is just exploding rapidly. Well, medicine, I've said for my whole career, the last great frontier of medicine to me is the human brain. We know nothing. Yes, we do. Don't get my neurosurgical friends on my case, but we don't understand a lot. You know, ALS, you know, obesity, psychiatric illnesses. I mean, some of those things haven't advanced since Sigmund Freud at the beginning of the 20th century. Those things we're going to be able, I think a lot of the neurological illnesses, ALS, all those things, I think MS, I think those will be be able to cure them.
That's wonderful.
Some of these genetic illnesses, they'll be able to go into a young child, turn off the gene, type 1 diabetes, you name it. There's a lot. Now, what comes out of all those advances? To me, one of the biggest things you talk about a new profession will be the not legality. What am I trying to say? You know, what right and wrong.
The ethics.
The ethics.
The ethics.
The ethics of it, because bioethics is going to be great. Is it going to be good that we lived 150 if we don't have food for the people that are living that long? You know, is that just going to cause more wars and famines and stuff? I don't know all that.
Right.
So that would be a problem. But I think it's going to be. I think the next decade is going to be amazing.
That's wonderful. That's very hopeful.
Yeah, developments of medicine.
Very hopeful.
That's my vision for the future.
All right. So back to the magic wand question. So here I'm going to say it a little bit differently. If you could fix one thing about the healthcare system, one thing, what would it be?
One thing. Well, let me think. I guess the key buzzword would be access.
Okay, that's true. It's a good.
Just access.
Access.
You know, every human being should have access.
Yeah, I have heard that it's also very difficult to get in with oncology. That those appointments are very delayed. Is that do you have any knowledge about that?
Well, I don't have any knowledge of that, but it's the specialty of hematology and oncology is that's one when we're talking about it with the development of the treatments for oncology is just going crazy fast.
It is.
It used to be, like I said before, once we talked, is that you write a book and a medical book would come out every decade, every 5 years. Hell, the technology and the terminology might change every 30 days, every 90 days now. In oncology, the developments and the changes are so rapid. And an example is President Carter lived a lot longer than he would have normally because of advances in oncology with what he had as his illness. So, and that's just that's just a little caveat of what can be. So, yeah.
Let me see how I can ask this question because I hear this often. So as you know, I'm a type 1. I have type 1 diabetes. And it's a gazillion dollar business or $1 billion business or whatever that amount is. So if there is a cure, does it help the people that are making so much money off of sick people?
Yeah, well, the deal...
What does that... Can you explain that? Break that down a little?
Yeah, I mean, I think I'll give you a simple example because I've dealt with this. I had sensorineural, they call it unilateral deafness, just went deaf in one ear one day.
Okay.
Now, they have the abilities now, they're developing and they're in research, but with stem cells, they can probably in the near term very quickly, somebody may argue, but I think they can cure hearing loss, okay? Well, who stands to lose if they cure hearing loss?
Hearing aid companies.
Right.
Yeah.
So who stands to lose if they cure diabetes? The insulin, the drug companies that make insulin, make pumps.
The technology, yes.
The wearable technology. Yeah. So that's where, I mean, there's argument over COVID and the money that was made off vaccines now. Who benefited from that? So I mean, that's where the rock hits the road there.
That would be another good podcast, Dr. Zollinger.
Yeah, well, that's a whole nother thing because that's the bioethics we were talking about.
Mm-hmm.
So if we come around and we cure all those illnesses, what about the companies? Hair loss and hair transplants, they can now take a little bit of your cells, grind them up, inject it through your scalp, and you regrow your hair, and you don't need anything done ever again, and you don't need surgery or whatever. Well,
Yeah.
But there are people making a lot of money doing that. So,
Were you frustrated at all when you would read? I mean, with COVID, we didn't know what was, someone like me, I didn't know what was going on.
I didn't know either.
No. Do we know more now?
About COVID?
Yeah, about COVID or where we went wrong, what we could have done. Did we get it right? I mean, those kinds of things.
Well, don't talk to 10 physicians about it.
Don't talk to 10 physicians? Do they all disagree?
They would be, I think you'd find 10 physicians and the majority would be very disgruntled with everything to do with COVID.
Okay.
I mean, I was right there with everybody else, and I took my initial vaccines, went down to the football stadium and everything because we were all told one thing, and then how the patients were handled in nursing homes. And the one thing that bothered me the most, which has come to light, was that there was no need for people under 18 to get a vaccine at all. Mm-hmm. And then they started having myocarditis and stuff like that. And, and to some degree, to me, the pandemic was, I want to know how it was differentiated from influenza pandemics and stuff, 1918 or whatever. We were told a lot of people died from it, but a lot of people were elderly and had other illnesses and stuff like that. I don't know.
Right.
But I came out of it, and it was the end of my trusting medical literature. I used to be able to read medical literature, and I knew where to take something with a grain of salt and say, I don't quite trust that. Now, I'm at a loss when I read things to you really have to study it to decide whether I think it's worthwhile or not.
Okay.
And there were specific journals that you are, New England Journal of Medicine, it's something like that. You said, well, 99% of what they print has at least been vetted.
Mm-hmm.
Not anymore.
Really?
I mean, it probably is. I'm not an editor, but they lost us. Now they got to get us back.
Right. What advice would you give patients who feel lost, unheard, or overwhelmed in today's healthcare system?
Get help. Find, that's where advocate, but get help. Find somebody who can help you. If it's a family member, you need to ask questions, and you need to go to bat for yourself. And and usually it involves having a family member help you, somebody support you. And if it's an external source like a patient advocate as you, then go for it.
Okay.
Yeah.
What about doctors that feel lost in the healthcare system today? What would you tell them?
Well, that's kind of
what you do.
What I got involved with. Now, my experience hasn't, I haven't coached thousands of physicians, but the experience is that's it. What the coaching for in business is in medicine, what you're doing is you're not giving them an answer. You're talking to the person, allowing them to kind of search in their own mind and find out, oh, okay, this is what I should do. Okay, find your own answer, and that's what coaching does for young physicians. So I think I think it's a really good thing. And I think a lot of businesses, hospital systems and stuff are recognizing that now.
So how can a healthcare professional or healthcare professionals and advocates work together better for the good of the patient?
Well, I think it's like what we just said. I think that the hospitals need to probably come up with a system where you have somebody who's labeled the patient advocate, and you give them their own little niche, and they work with outpatient patient advocates who can cross over into the hospital and that, and go to bat for the patient, and it's kind of at the beginnings of its growth. It's
right. It is.
It's like one of those things. Well, why do we need it? Well, right now we do.
Right, we do.
Yeah,
we do. And the final question, is there anything else you wish people understood about the realities of modern medicine?
Well, a simple answer to that is it's the practice of medicine. It is called the practice of medicine, and nothing's 100%. So there's not always a right or wrong answer to every problem you might have. And there may be a solution that you don't see, or the doctor doesn't see, somebody else sees. So you have to be open-minded. Okay. But that's what I'd say.
Well, thank you. And thank you for coming back.
Sure.
I want to bring you back again. There's so many things I want to talk about, so many different subjects that I think are important. Education is key. And I really appreciate you being a part of my patient advocate. And thank you for being here today.
Yeah, I enjoyed it.
Thank you.
Thanks for having me.
Thank you.
Bye.